Session, we'll hear from Dr. Jeffrey Joseph, who will be speaking on the development and testing of medical devices designed to improve clinical outcomes. Dr. Joseph has worked as a clinician and research scientist in the Department of Anesthesiology and Perioperative Medicine at the Sidney Kimmel Medical College, Thomas and Jefferson University for more than 35 years. His research has focused on the development and testing of medical devices with a focus on the physiologic sensors, drug delivery systems, and algorithms that enhance the accurately and timeliness of diagnosis, leading to improved clinical outcomes. And I'd also add improved caregiver outcomes too. You make our job easier. Dr. Joseph is an inventor and a serial entrepreneur, co-founding 3 medical device companies spun out of his academic laboratory. Please join me in welcoming Dr. Joseph.
Thank you for the introduction and thank you for the invitation to the meeting. Today we're going to discuss the last 30 years of my life, trying to identify a clinical problem and trying to invent a medical device to solve that problem. Coming up with the concept is sometimes the easy part. Getting people to believe in your idea and to get resources to implement that idea is sometimes the hard part. These are my financial disclosures. I do work with a lot of industry. I also have been lucky to get funding through NIH through the years, as well as DoD. So the goal here is to understand how to identify clinical problems and how to come up with solutions for those clinical problems. And many of those in our industry are medical devices, not just drugs. So we co-founded with a colleague of mine, Mark Torsman. We've been working together for 35 years. The concept of a artificial pancreas center, which go back into the early 90s, you were treating diabetes with intermittent injections of insulin. So we came up with the concept of developing a glucose sensor, connecting it to an insulin pump with an algorithm and closing the loop. And here it is, almost 30 years later, and it is now the standard of care for type 1 diabetes management. But in the beginning, you tried to get people to believe in this idea, and they said, this is too hard, this is too expensive, this is too risky for the patient. Patients will never be able to figure out how to use this complex technology, but the opposite occurred. You gave them the technology, and they fairly quickly figured out how to use it. And the beauty is they wake up in the morning and they have glucose under control. The worst thing in the world, in the real world, is you wake up and your glucose is 250 and you have to get up, go to school or go to work. Now people wake up in the morning with good glucose control. However, go back into the early 90s and we tried to get this off the ground, and I contacted the American Diabetes Association and said, let's put together a session on that. And they go, no one's interested. And then I said, I wrote a grant to NIH to try to take this concept and build it. And they said, we're not funding you. You're not an engineer. You're not an optics person. You're not a this, you're not a that. But it's a good idea, but we're not giving you the funding. So what I learned is you need to put together a team of people, resources, not just money, but the appropriate people in place for each of the technology that you're trying to develop. So with that in mind, I went to the Borders bookstore, purchased a book on writing a business plan. The first technology was an optical sensor, bought a book on optics, went on vacation, read the book on optics, wrote a business plan, wrote a patent application, and started a company. However, imagine if I came to your house and said, please write me a big check to try to get this concept off the ground. And 26 people later, I got no after no after no. And the next person said, hey, this is a good idea, and wrote a check for $1 million to get the concept off the ground. So the lesson I learned when I was a young assistant professor is to be persistent and to put together a good team of people. So in addition, I tried to get NIH funding. So I mentioned that the first one that I submitted, the first grant, it got rejected. The second grant application I submitted, it got rejected. So I contacted NIH and said, how do I get on the committee that reviews these grants? And they go, you're too young, you don't have the background, you're not published in this area very much. So I said, please, I can go as an observer. Within 4 years, I was the chairman of the committee, and I started to get grant funding. Okay, so the answer is to work really hard, and when people say no, kind of just keep pushing ahead. So that's the background. Here's the initial concept. Think about people with type 1 diabetes would prick their finger multiple times per day, inject insulin multiple times per day. This is well before nowadays sensors are very commonplace. You see them advertised on television, but back then this was a new concept. And I worked with pulse oximetry as an intern and as a resident, and so we came up with the concept of an implantable optical sensor. Think of a spectrometer that you implant. And I had done work with flow probes around blood vessels, and basically we did spectroscopy of flowing blood. And in your upper left-hand corner, you can see an early, this is from one of my early patents, an optical sensor around the peritoneal and parietal membrane, a vascular membrane, and we did spectroscopy of tissue. We also made sensors that go around the outside of a blood vessel, and in the bottom you can see I would skeletonize a blood vessel, a small artery or vein, and put this miniature sensor around it, and we did spectroscopy of flowing blood. And there's my index finger showing the sensor inserted around a vessel. And then we got all the way through animal research into human clinical trials. I finally got funding from NIH. And here is our volunteer as a type 1 diabetic. He actually was one of the engineers in the company that we helped found. The company's name was Animus Corporation. That's Latin for body and soul. And so we actually got into human trials, but initially we didn't want to. You can't do a surgical implantation. So I put an IV in. We drew blood out of the IV into this optical sensor, which is next to the patient. And in the left, you can see there's an infusion pump. And I gave intravenous insulin, and we manipulated the glucose from a low of 50 up to 250, back down to 50. And we simultaneously measured blood glucose, and we demonstrated the feasibility that you could use optics to measure the concentration of blood glucose, as well as we did ketones, of the things that you want to measure for diabetes management. And here's some of the data just showing as we manipulated the glucose up and down, and we got an R-square more than 0.98. So we showed feasibility. NIH liked what we're doing. And so that company initially was founded on this concept of this glucose sensor, but I learned very quickly that to get people to fund your research and to pay attention, you need a product for sale. So I wrote a prescription for the 2 insulin pumps on the market, one in Europe and one in the US, took the pumps apart, figured out how an insulin pump works, and within less than a year, we had a pump developed and through the FDA, and we had a product with sales. And the first year sales were 20 million, the next year sales were 40 million. And we went from an idea, a concept, to a company with 800 employees, went on the NASDAQ stock exchange, and then 2 years later, J&J bought the company for $518 million. So I retired, played 2 rounds of golf, and went back to work. So the beauty is some of that money came to the university, and it funded the research division of our department for almost 10 years. So that was the positive side of being an entrepreneur in an academic setting. So moving on, our university got a new president, and he had one of the pillars of the university was innovation and entrepreneurship. And he said, Jeff, can you please mentor the other faculty how to be an entrepreneurial? So I said, let me try to lead by example. I said, let me start another company, and I will use that to teach the other faculty. So we co-founded a company called Capillary Biomedical, again, around diabetes technology. And just to refresh your memory, an insulin pump is a little pump that's external, and you give a little bit of insulin, basal amount of insulin, minute by minute. You push a button or two, and you give a bolus with each meal. And basically, that's the basics of an insulin pump, insulin delivery. But the weak link or the Achilles heel was what goes under the skin. When you insert something under the skin, you're causing tissue damage, you get acute inflammation, and you're delivering insulin, which is a three-dimensional peptide, into an area of inflammation. And in the real world, you needed to take out the old cannula and put in a new one every 2 to 3 days. So you're talking about 100 of those a year. And in the middle of all this, now the other glucose sensors that are now on the market have a little needle and an electrode that goes under the skin. So you're inserting hundreds of the devices into the subcutaneous tissue per year. A type 1 diabetic typically gets diagnosed at the age of 6 to 8. So in their lifetime, they're getting all these things inserted into the subcutaneous tissue. It develops fibrous tissue and scar tissue when you lose sites because they lose their vascularity. So the concept of this new company, Capillary Biomedical, is making a better insulin infusion set that didn't cause these problems. And the other thing with sub-Q insulin is when you inject it, you want to have rapid onset because as you're eating your meal, you want the insulin to take effect, but you also want rapid offset so you don't get hypoglycemic postprandial. But when you give sub-Q insulin, it's actually rather slow and rather variable in its absorption, and both its PK and PD are highly variable. So we submitted grant applications, and being academic, you're typically writing your grant applications on weekends and nights, and it's like you're having two jobs. You're working in the university setting and you're trying to grow a company, and sometimes that can be challenging time-wise. So this is showing what a current commercial infusion set looks like. You see the little Teflon cannula. It's 6 to 8 millimeters in length. It's actually fairly rigid. There's a needle that goes through it to get it through the epidermis and dermis into the subcutaneous tissue. The needle comes out, leaving that Teflon cannula under the skin. And you can see that the insulin pump looks like a fancy cell phone. And basically, they're very sophisticated nowadays, where they have all this software where, let's say you go out to a restaurant, you can put in the food that you're eating, and they have a library of foods, and they help you decide how much insulin is necessary to give. That's open loop, but where things are now heading or commonplace is closed loop artificial pancreas, which is called automated insulin delivery. And that is the sensor makes a measurement every 5 minutes, and that measurement goes into the insulin pump, and that insulin pump calculates how much insulin do I need to give over the next 5 minutes, and then it updates it the next 5 minutes. So it is able to almost clamp the glucose level at the desired range. The limitations are around large meals, and the limitations are around exercise. They're the things we're currently working on to get tight glycemic control. And we've learned through the years that tight glucose control is important in terms of microvascular disease, but as important, studies have shown the control of glucose and blood pressure are most important for preventing chronic kidney disease, but more importantly, myocardial infarction and stroke, macrovascular disease. So the goal is improving patient outcome with tight glycemic control. So we do a lot of animal work. Many of our animals get adopted to families, and to petting zoos. I'm a real animal lover. This is a swine. His name is Hungry because no matter how much I fed him, he continued to want more. You can see the animal is wearing a vest. We put glucose sensors and insulin delivery systems in pockets, and they wear anywhere from 6 to 12 insulin pumps, and we deliver things into the subcutaneous tissue to compare the investigational device to a control device. That's the belly of an animal, and on one side are the investigational, the other side are the commercial devices, and you can see a couple glucose sensors underneath. Just normal anatomy of the epidermis, dermis, and subcutaneous tissue. I bring to your attention the connective tissue layers are nice and thin and parallel with the dermis, and the white are your adipose cells. So this is a take-home message slide, what happens in the real world. In the upper panel, that's the Teflon cannula that's commercially available that I showed previously. On the bottom panel is stainless steel cannula. Many people need stainless steel if they have reactions to the Teflon, and the Teflon is prone to kinking in the real world, especially in kids. So this is what's commercially out there. But starting on the left-hand side, you can see freshly inserted, you're damaging tissue. So anytime you damage the connective tissue, the adipose cells, you're releasing triglycerides, you're releasing all the contents of the cells into this area, and you get an inflammatory process that initiates right away just due to the damage of the tissue. As you progress to 8 hours, you can see this is now the upper portion. It says 8 hours. The connective tissue septae are starting to thicken, and that is neutrophils, macrophages are being brought to that area because of the tissue damage in the foreign body. But as you progress to day 3 and day 5 and day 7, that area of inflammation starts to thicken and become denser, and now you actually have a mechanical barrier around the cannula, and you're delivering the insulin into this area of acute inflammation, and these cells are secreting proteases and other things that digest the insulin. So basically, when I said earlier that insulin absorption is highly variable, we're the first academic lab that really figured out the mechanisms why there is variability, and we tried to invent things to try to overcome this type of inflammatory reaction. In the bottom, you see the stainless steel, and as you go out to day 3, day 5, and day 7, because it's a steel cannula and there's movement, there's quite a bit of tissue damage that occurs. So what's the solution? The solution took us 6.5 years of iterative process to figure out how to make it work. The solution, if you look on the far right, we came up with a soft, flexible cannula that is made out of a nylon material that is somewhat rigid to get as you insert it at room temperature, but as it goes to body temperature, it becomes very soft like limp spaghetti because you don't want to have ongoing damage of the tissue. But now that it's soft and flexible, you worry about kinking, so we worked with engineers to put a wire reinforcement in the wall like a slinky, and we figured out how many coils per centimeter and all that kind of stuff. And then we've said, well, if a lot of times one hole, traditional catheters have one distal hole, we said we want to have multiple holes like a soaker needle. Okay, so we tried 28 holes and 14 holes and 8 holes, and we ended up coming up with 4 holes of a certain size for redundancy and to spread the insulin into a greater surface area for rapid onset and rapid offset. And in the bottom, or actually in the middle, you can see we do micro CT of the tissue after delivering a bolus. We put a little bit of X-ray contrast agent, and you can see the greenish color is the insulin coming out in a high concentration from these holes, and the bluish is lower concentration. So this device, it took us 8 years to get to this point, and then that company got acquired by a insulin pump company, about 2.5 years ago, and that pump company is now doing a $32 million multi-center clinical trial around the US as well as Europe to bring this product to market. Okay, so it took a long time and it took an iterative process, but we're in the process of getting it to the market to help patients. Now we're going to shift gears. I learned a long time ago to always have plan B. If that insulin delivery company got a certain point and then died a quick death, you needed to have something else to do. So started another company. This company's called RTM Vital Signs for real-time monitoring of vital signs. And this is more related to what we do for a living. The concept is wearable implantable vital signs as well as wearable and implantable. And I'll show you a few examples. And because nowadays machine learning, AI, pattern recognition, whatever you want to call it, the whole concept is finding subtle patterns in these vital sign trends for early and accurate diagnosis of clinical deterioration. And we've been lucky to get quite a bit of NIH funding to make this happen. For the next few slides, I'm going to talk about what we're currently focusing on. This is a wearable sensor. Think of a pediatric stethoscope head, a Bell stethoscope with a very thin membrane or diaphragm on it, and it is adhered to the sternal, over the trachea on the sternal notch. It has two small microphones facing the body and one microphone facing the environment, and it listens to airflow as you breathe. And we've been able to, after quite a bit of data collection and modeling of the data, we can accurately measure respiratory rate, tidal volume, the pattern of breathing, duration of apnea, the degree of snoring, and all of these things are important in terms of detecting clinical deterioration in the hospital and the outpatient setting. So this is what an early prototype looks like. And again, the whole idea on the general floor of the hospital, patients their vital signs are monitored every 4 to 6 hours, and clinical deterioration is commonly missed or delayed. And the concept is to have this very low-cost wearable sensor with algorithms to detect subtle changes and make algorithms that alert and alarm and avoid false alarms because it leads to alarm fatigue. That's the challenge. And it looks simple, but it's taken us about 4 years to get to this point. I mentioned the things. We're currently adding a pulse oximeter to it. We're adding an accelerometer for body position and activity level and skin temperature. So this is the output. It's a microphone. So this is the output signal, inhalation, exhalation, inhalation, exhalation. However, in a noisy environment, I mentioned there's a microphone facing the environment. We've worked with engineers to do active noise cancellation, and we've gotten to the point where you don't even hear the external noises. This is just showing one of our research. This is on a tablet at the bedside, and basically you have a trend of respiratory rate, tidal volume, apnea, all these things at the bedside, and we're currently working with engineers to make this simplified, that someone on the general floor of the hospital, you don't want it to be too complicated. You want it to turn red when it's appropriate to alert and alarm for the clinical nurse. The data, we're working with the electronic medical record people, Epic at our institution, and basically the data as well as alerts and alarms will go real time to the bedside nurse. And for opioid overdose, as an example, it's necessary to have real-time alerts and alarms and not alarm inappropriately. This is hard to see, but this is we have 11 issued patents, and 3 of them are for the algorithm. And I mentioned we do a lot of diabetes and glucose management, which is all trend data, the direction of change, the rate of change. So we got intellectual property based upon pulse oximeter. So instead of a threshold, you fall below 88% on your pulse ox, the variability of the pulse oximeter over time, the variability of the respiratory rate, the variability of the tidal volume, how many apnea events and the duration of that apnea events, they all go into a machine learning algorithm to make alerts and alarms that are more appropriate and try to avoid false alarms. So this is a medical student who took a gap year. He wants to be a medical device, an entrepreneur. He's wearing a face mask with pneumatics, which measure airflow accurately. And underneath is our wearable sensor. And we bring volunteers into the lab. We've tested patients in the OR. We've tested patients on the general floor in the pulmonary function lab. But mostly we bring people into our research laboratory. The more data you collect and model, the better the algorithm becomes. And this is showing the second one down. I just want to show you that is the reference device, the pneumatac, normal tidal volume, shallow tidal volume, normal tidal volume, deep tidal volume. Breathe slow, breathe fast, hold your breath. We have the volunteers do that. And then the third one down shows the correlation that we can use sound to accurately measure tidal volume. And that's been the hardest part. Respiratory rate's easy. You hear vascular and heart sounds, so heart rate is easy. Okay. The thing that has been the challenge is accurately measuring depth of breathing or tidal volume, and it's taken us about 4 years to get to where we are. And this is also showing the correlation on the far left is deep tidal volume, normal tidal volume, a period of apnea, shallow tidal volume. And this is the type of data you submit to NIH. And I'm very happy to say that NIH just granted us a $2.7 million award that we're going to be putting this on postoperative surgical patients managed with opioids. And they're very interested in us being able to detect, and we promised even predict, leading to severe respiratory depression due to opioids in the postoperative period. And that's just showing trends. 11 issued patents so far. And when you think about getting something to market to help patients, companies, the goal is to show feasibility, but you need to patent the heck out of your idea. So the next step is to get a company to commercialize it, take that risk if they believe in your data and your technology. So a patent is a license from the federal government to exclude others 20 years from the data file. So the more patents you have, a wall around your technology, the better chance that a company like Philips or Medtronic or Edwards Life Science will pick up on this and bring this to the market and help you bring it to the market. We presented this as a scientific exhibit at the ASA meeting, and I'm excited to say that we won the first place prize for innovation at the ASA this year. Okay, we're transitioning now to a totally different concept, okay? The company RTM was founded around this technology. It's an implantable cardiovascular monitor, okay? Think of a tonometer, a Sheets tonometer. Remember, you press on the eyeball and flatten it slightly to measure intraocular pressure. Well, this is an implantable tonometer that goes around the outside of a small peripheral artery, and I'll show you in a second how we do it. And basically, it gives you beat by beat the arterial waveform, just like you have a catheter in the radial artery. Okay, so this is a hard sell because it's implantable. We're in discussion with the companies that make LVADs as an input to that, to defibrillators, the hemodynamic significance of the arrhythmia that the defibrillator shocks at the appropriate time, and also people that are very severe hypertension. There are 3.5 million people that are on 4 or more antihypertensive medicines and still poorly controlled. So it's a hard sell, but there's an emerging market of implantable devices, and we're trying to see where this might fit in. So we spent about $2.5 million with engineers, and we made this implantable tonometer that goes around a vessel. In the bottom right-hand corner, you can see I implanted that around a small peripheral artery in large animals. During the pandemic, I would come in to the laboratory every week or so, anesthetize the animal, put in an A-line, manipulate the blood pressure up and down, the heart rate up and down to show the accuracy of the device. And the cartoon on your left shows where we would implant it, and I put it in many cadavers. You want to be at the level of the aortic valve because that's the 0 point, so gravity doesn't affect your measurement. So this is the concept, not just the arterial waveform, but our future is all the things that you guys monitor in the OR and the ICU, we would love to have for certain groups of people with severe heart failure, with bad valve disease. 1,000 people a day die sudden death in the US, okay? There's no data really what leads up to that. We say it's an arrhythmia, but imagine somebody comes into the emergency room with chest pain and they're in pulmonary edema, heart failure. You can download this recorded data and see what's happened over the previous 24 hours or even the previous several days. And that's the concept. The hard part is getting people to believe in this and take a concept, an idea, and get it to market. So this is what we designed, what we built. And basically, it opens up. You skeletonize about 1 centimeter of a small vessel, about 1.5 millimeter vessel. You put this device around it, and on your right-hand side, in the very middle, you see a 1 millimeter by 0.5 millimeter diaphragm, and that is the miniature pressure or force transducer that sits on the outside of the vessel. We put all this effort into not putting anything intravascular. We want to be on the outside of the vessel. So we came up with a couple different designs. The one on the left has some compliance with, it's a little bit springy. On the one on the right is more of a less compliant, and we found the one on the right has better stability. We could calibrate it, and then it would stay stable and not require another calibration for several months. And this is what you get out of the sensor, just like a catheter in a radial artery. And because where you're located, it's actually your central aortic pressure. Okay, so we're pretty excited. And just to refresh your memory, that there are products on the market now, Edwards Life Science and others, that are taking this waveform and making important clinical decisions based upon the upstroke, the area under the curve, where the dicrotic notch is, and basically they're giving you estimates of stroke volume and cardiac output and peripheral resistance, and that data currently isn't available in the real-world setting in outpatients. And just to remind you what essential hypertension is, in young people with very compliant arteries, as the left ventricle contracts, the pressure wave goes out to the periphery, and then it's reflected back towards the heart at a certain speed, and it occurs during diastole, and that next forward pressure wave and that reflected pressure wave, they summate in diastole, which augments coronary artery blood flow. But as you hit the age of 40 and beyond, your arteries get stiffer, and that reflected pressure wave comes back faster, and now it summates on the forward pressure wave during systole, and that on the slide it says augmentation pressure, and that summation of the forward and backward pressure wave, that is what is essential hypertension. So basically, the concept of managing hypertension may totally change if this type of data is available in the real world in outpatients. And this is just showing some of our data. So 3 months, 6 months, we have data out a year in a large animal model. This is showing in the animal operating room, as the ventilator fired and you got positive pressure ventilation, each time you gave positive pressure, you would get a dip in your blood pressure waveform, and basically these showed the sensitivity of the sensor. Okay, shifting gears again, okay? And I don't want to confuse you, I just want to tell you that my brain's a little schizophrenic. I keep coming up with new ideas and trying new ideas, okay? This is work we did starting 15 years ago with Medtronic and Dexcom and Abbott, and basically these are the sub-Q glucose sensors, and we are trying to get FDA approval for using sensors in the hospital setting. Here's a patient about to have coronary artery bypass surgery, and we would routinely put sensors on these patients and correlate it with blood glucose, and that data would go to FDA to try to get approval. Medtronic came up with a sensor specifically for the hospital the hospital environment, and we did all of their testing. And this is showing, instead of intermittent point glucose values, you have a glucose value every 5 minutes, and it's actually very accurate. So here's an example. We did a study that each morning I would come in and I'd look at the database from our AccuChecks, was on the computer, and I looked at let's say 25 people that developed a glucose below 50 the day before. And I'd run out to the patient's bedside, sign them up with informed consent, and I'd ask permission to put sensors on them because they had a hypo event. Maybe I'll catch another hypo event. And the fourth patient that we did this to had a orthopedic ankle surgery, type 1 diabetic, at 1700. So on the y-axis is glucose concentration, the x-axis is time, and at 1700 around the meal time, the day nurse, the patient ate dinner but forgot to give the short-acting insulin to cover that meal. So that was a mistake. Okay, and then at 2200, when the night nurse came in and said, "Oh, the meal insulin was forgotten. I better give the meal insulin," and then they gave the long-acting insulin, the peakless insulin that was also ordered at 2200, and then the patient went to sleep, turned off the lights in the room. This is on the general floor, and then at 7 a.m. The patient was unarousable, had a severe hypo event. They caught a rapid response. They gave intravenous glucose. You can see the glucose rising quickly. All those little dots are the finger sticks, and basically patient had no permanent injury from here, but this, when we publish this is often used when we went in front of the FDA. This is why sensors are necessary in the hospital. Not just to maintain between 140 and 180, but to avoid severe hypoglycemia. Moving on, we did a study. The company needed hypoglycemia data to submit to the FDA, so I took on the challenge of bringing diabetics into the lab, and we actually took them from a normal glucose value down to 50 and clamped it at 50, back up to 250, back down to 50, and this is the data that the company used to show accuracy in the hypo range. Okay, so this is now a company called Dexcom. I'm sure you've seen advertisements on TV now for a glucose sensor. There's Medtronic, there's Dexcom, and there's Abbott, okay? All of them are now pushing me to do clinical trials in the hospital. Dexcom's the earliest. We just finished a 9-center, multi-center clinical trial. The data is excellent, so you will have sensors in the hospital probably within the next year. This is all being presented to FDA now. Okay, shifting gears a little bit. For in-hospital glucose monitoring, these sub-Q sensors are good, but if you have low perfusion, if you're cold, but mostly low perfusion, they don't work as well. So other people have worked on vascular sensors. So here is putting in an A-line in the radial artery, but you can see on your right-hand side the size of the catheter relative to the diameter of the inner lumen of the radial artery. And we do ultrasound work to see the location of the artery and the velocity of flow through the artery. And this is the take-home message. In the upper left-hand corner is the velocity of flow through the radial artery right before we put the 20-gauge catheter in the radial artery. And on the bottom left is the velocity of flow in the ulnar artery in the same hand. But in the upper right, as soon as you put the catheter in, you're partially obstructing that lumen. You get some vasoconstriction, so the radial artery becomes not, instead of a high flow, high shear force environment to keep the sensor from getting clogged and thrombosed, it becomes a low flow, low shear environment, and the ulnar artery flow greatly increases. So we thought that was an appropriate location to put it, but it turned out to fail because thrombosis was very common. I like this picture because we did a lot of work using the radial artery as a conduit for a glucose sensor, but we have a camera that measures temperature, uses infrared technology. On the left-hand side you see a nice warm hand, it's all red, right after the catheter is put in. But after a few days of use, you can see that certain fingers are colder than other fingers. Okay? And even though ischemia of the tissue was uncommon, little microemboli go out to the digital arteries, and that's somewhat problematic because we had issues with thrombosis of the radial artery just with the catheter, but then when you put a sensor through the catheter, you had even increased thrombosis. Last two slides. The first invention that I ever got to market and made a royalty payment or a royalty check I got in the mail, this is going back to the mid-90s. The concept of suctioning below the vocal cords and above the inflated cuff, we had the idea that if you continuously suctioned, and we also made a control device that regulated cuff pressure, it irrigated the area above the cuff. So we irrigated and drained, indeed, the area above the inflated cuff with the idea of preventing ventilator-acquired pneumonia. And so we patented it. I think I made 100 different prototypes, got IP or issued patents around it, worked with companies and brought it to market. And that was the very first thing that I ever got patented. And then just a couple years ago, we worked with a company to try to bring the next generation to market. And we did a dye study where half the patients got a traditional endotracheal tube without suction, and the other half got an endotracheal tube with this new subglottic suction endotracheal tube. And we put dilute methylene blue dye behind the tongue and then every 15 minutes we put a bronchoscope down and did a video to see, did the dye migrate down below the cuff. And basically with a traditional tube, even with these modern where they claim that they're soft and they prevent microaspiration, we found that dye got down into the lower trachea and into the proximal bronchi fairly commonly. And when we had the subglottic suction, that did not occur. So we're pretty excited to show this data, and we're right now writing this up as a manuscript. And I think that's enough for right now, and I'll stop and take questions.
Wow, what a thought-provoking professional journey you've had there. I know I'm not the first, and I certainly won't be the last, but thanks for your contributions to science medicine in the field of anesthesiology. Really an excellent presentation. As Dr. Joseph said, we'd like to open the floor to any questions the group here in person might have. If there aren't any, I'd like to make a comment. I find myself at any presentation being a bit envious of the obligatory second slide of financial disclosures. And I think what you taught me today with your presentation was that maybe that envy should be a little more thanks. Because I think the time, the thought, the innovations that you've provided, if it hasn't yet, it definitely will make our ability to care for patients easier in the future. So I want to thank you for that.
May I make a statement?
Please.
Since I have a minute, I'll tell you a story. When we came up with this concept of artificial pancreas and closing the loop, and we got NIH funding to test this optical glucose sensor in humans, 2.5 years of effort went into getting FDA approval and IRB approval and working with engineers to make the device, and all this effort. And a week before doing the very first human person in our lab, I got a nasty letter from the university attorney saying I could not do the work. They got wet feet that if someone got injured during this, and I had a conflict of interest and the university had a conflict of interest, they got scared that they would be in the newspaper. And I'm thinking, you had 2.5 years of knowledge to get to this point. You can't tell me a week before that I can't go ahead and do this. I welcome any oversight and anything to make this safe, but I'm going to go ahead because this is my life. I want to see this happen. And basically I had a predicament. So what do? I went home really upset. And then I contacted the university attorney again and said, I'm going to go ahead and do this. And I thought I was going to be fired. And basically, I went ahead and did the research, and the patients did fine. And after the study was over and no one had a complication, I then got a letter from the university saying, you can go ahead and do the work. Okay, and I tell this story only because so many, you're trying to come up with new ideas and breakthroughs to help patients, but things get in the way. And through the years, I've taken many personal risks and financial risks to get some of the things I showed you. And it's been a journey. And being in an academic setting, I'm trying to now educate the current attorneys and the current administration that they should be more open and allow the people that have the vision to do the work. And I know there's the concept of conflict of interest, but there's also the conflict of you're the most knowledgeable and motivated person to get this to market. So I'm on the soapbox today for that. Questions at all?
Well, I was just going to say, I find your comments intriguing, and I think we as physicians, as anesthesiologists, have a role and responsibility outside of the four walls of the operating room, of the critical care ward, and of the hospital. So I appreciate you bringing up that point that our roles, obligations, and responsibilities extend beyond. Quick question for you. You mentioned Edwards Life Sciences. I'm an anesthesiologist in Cleveland, and we recently just got their novel product. I guess it's been out a little bit longer, but Insight. So it's a finger cuff, and assuming good perfusion, there's no need for continuous blood sampling. We use that, and with the arterial waveform that you eloquently described, we're able to extrapolate many data points. Your technology seems to be trending more implantable. Would you care to comment on the accuracy of implantable versus the finger cuff that Edwards currently has?
So thank you. So the Edwards product has been demonstrated comparing to an A-line, and it has an accurate correlation and has a good waveform, and they're able to measure not just systolic mean diastolic pressure, but other parameters based upon that waveform. So it is a very good technology, but you need to be, once you calibrate it, you need to be in a fairly still. All of wearable technologies have an issue with motion artifact, okay, and body position. So the answer is yes, it's a very good product, and I think that it's going to be more commonly used in the future. Of interest, I mentored a PhD or a person that was in my lab as an undergraduate biomedical engineer and then a master's and then a PhD student. Then I got to hire him as an assistant professor in my lab. He's a biomedical engineer, and I took 9 years of training this guy, and then Edwards Life Science hired him away, moved him to California, tripled his salary, and he loves being in California. And he's an algorithm person, okay? And he contacted me just last week, and of interest, Edwards Life Science sold their entire in-hospital monitoring division to Becton Dickinson. And this just happened 5 days ago. And now Becton Dickinson, you're going to see, is getting into our area of interest. And you're going to see they have a whole list of new ideas that they want to see tested. So if you're interested, contact BD, and hopefully there'll be research dollars out there to test these new products.
Great stuff. If there's no other questions on behalf of the college, I'd like to thank Dr. Joseph for his time, expertise, and very eloquent presentation today. Thank you, Dr. Joseph.